Right. Good morning or good afternoon, everybody, wherever you are in the world. Thank you very much for joining us today for the second session of the webinar series jointly organized by the Egyptian Committee for Pathology Training and Diagnostic. We're privileged today to have with us Dr. Sangeetha Kalimuthu, who is a pathologist at the University Health Network in Toronto, Canada. She specializes in gastrointestinal pathology, and in addition to her experience in pancreatic and soft tissue pathology, she's also an assistant professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Her work focusing on cancer research and improved diagnostic classification methods. Dr. Kalimuthu, thank you very much for sharing your time and expertise with us today, and we look forward to hear from you.
Super. Thank you very much for that very generous introduction. And yes, a very good afternoon and good morning, as you mentioned. We could be in different parts of the world. And as the title suggests, today I'd be talking about the approach to gastric biopsy. Perhaps the gastric biopsy is somewhat ubiquitous in our everyday practice. I mean, we all see them, irrespective of what you do. There's always an abundance of gastric biopsies, GI biopsies within departments. And perhaps, the best approach would be to be cognizant of the variable histology that you see in the different compartments within the stomach, and also the physiology associated with these different compartments, or the different types of mucosa that you can actually, you encounter within the stomach. So this is a full thickness section, as you can see on the screen, of the stomach. The stomach is no different from anywhere in the GI tract, which is, sort of nicely organized into mucosa, with submucosa following the muscularis propria, or muscle, and serosa. So that is sort of the histological organization of the stomach. And
I'm sorry to interrupt, but I can't see your screen on my end.
Oh, right. One sec. And okay. How might we? Should I share it again?
Yes. Please, yeah. I think we've lost it.
Okay. All right. Share. Can you see it now?
Yes. Thank you.
Brilliant. Okay. Very good. Apologies for the technical challenges. Anyway, sorry. Going back. Sorry. It's gone forward. 1 second. Sorry. Okay. This was the slide.
Okay. Good.
Okay, this was the slide that I was on, and as mentioned, I'm simply demonstrating that in gastric biopsies, you usually encounter the mucosa, and sometimes, if you're lucky, you get a sort of snippet of the superficial submucosa. So, and in terms of, and speaking of the physiology and the variable histology within these different compartments, the stomach, the stomach is mainly comprising of the body and fundus. It encompasses most of the stomach in general. And the type of mucosa that you get is oxyntic mucosa. And it comprises the parietal cells, which are these sort of very tinctorially bright pink eosinophilic polygonal to pyramidal cells highlighted by the arrowheads, if you can see those, and chief cells, the more darker, grungy, smaller blue, round blue cells, and less conspicuous in the body or oxyntic mucosa, you have mucus gland cells. And in comparison, so in comparison, the antrum or the pylorus have a lot less or very infrequent number of parietal cells. I mean, they're very few and far between, really. And you have a greater abundance of mucus gland cells. And you have these antral cells with these fried egg G cells. I mean, they look like fried eggs, and they're very prominent, and they sort of stud the gastric antral cells. And they are the G cells which secrete gastrin, which we'll talk about a little bit more later. So these are the histological comparisons, or the regions within the stomach, and to understand in terms of the histology and its organizational structure, the fundus is usually in the proximal and central stomach. The pits tend to be shorter. In the antrum, they're deeper. In the cardia, it may be variable. The parietal cells, chief cells, as mentioned, are mainly in the body and fundus. However, you can rarely see them, parietal cells at least, in the antrum and cardia. You can see some chief cells very rarely in the antrum, but they're practically absent in the cardia. And there's a greater abundance of mucus cells within the antrum and cardia. And in terms of the endocrine cells, enterochromaffin-like cells are present within the gastric body, which secrete histamine. And the G cells, as mentioned previously, secrete gastrin. The D cells or delta cells secrete somatostatin, and the cardia has few endocrine cells. Oh, sorry, I keep doing that. Right, okay. So in terms of its function, so the major secretory functions of the body and fundus are the acid or hydrochloric acid, intrinsic factor, pepsinogen, which is secreted by the chief cells, and there's a lot of mucus is usually secreted from the antrum and cardia. And in terms of its hormonal role, histamine is secreted from the enterochromaffin-like cells, and gastrin again from the G cells. And there's, hardly anything within the cardia in terms of that. But ultimately, the diseases associated, such as autoimmune gastritis, H. pylori gastritis, carditis, and reflux esophagitis, can functionally sort of disrupt the normal physiology of the stomach. And that's why knowing these entities is important to be able to treat these different ailments. So obviously, within the remit of this webinar, we won't be able to cover, or I won't be able to cover every single entity that we may come across in the gastric biopsy. However, I wish to focus on several gastritis patterns or common gastritis patterns that we may see, and also polyps and neoplastic processes that we might see more commonly or more typically in your everyday practice. And to begin, I suppose I'd like to mention the Sydney scoring system, which is a standardized, systematic histological scoring system of gastritis, which takes into, or rather integrates topography, which is site, histology and morphology, and ties it in with the etiology. So usually it's graded mild, moderate. I typically say mild, moderate, and severe, or marked, but you can also score it from 0 to 3. And in terms of the inflammation, chronic inflammation is usually graded depending on the density. I mean, this is a semi-quantitative assessment, of course, and you grade based on the density of lymphocytes and plasma cells, increased inflammatory cells within the lamina propria. And in terms of activity is measured by the presence of neutrophils within epithelium or pits or within the lamina propria. And of course, Helicobacter pylori, I mean, we see that that's a very frequent sort of clinical query in the sort of everyday clinical setting. You can comment on the density of the organisms. However, they tend to be in abundance, and when they're infrequently there, you can say it, but I don't typically say mild, moderate, severe, or give it a score particularly. And going back to sort of the destructive features that may occur within the typical sort of mucosa of the stomach, it's important to comment on the replacement of the normal native glands by, say, fibrosis or metaplastic glands, and also the replacement of the normal gastric epithelium with intestinal metaplasia. So I'd like to begin with reactive gastropathy or reactive gastritis. It's a chemical injury, rather pattern seen in chemical injury. The most common causes are NSAIDs, bile reflux, alcohol, medication, chemotherapy, and it effectively indicates chronic mucosal injury. It may cause dyspepsia and bleeding, and ultimately removing the cause and treating with acid suppression with PPIs will actually treat this. But this is, somewhat ubiquitous, really. In our practice, you see it so commonly, and it really varies in terms of the degree of changes that you might see. And this is a more classic sort of reactive gastropathy type pattern. You have gastric foveolar hyperplasia, and you have hyperplastic foveolar epithelium, and it really sort of resembles the sort of pulp of grapefruit. and the pits tend to be tortuous and have this corkscrew-like pattern, as you may be commonly used to that term, the corkscrewing pattern. And this can vary significantly. It could be very dramatic, or it could be very mild and subtle. And I would say in this particular example, it's somewhat in the middle. And you can have fibromuscular hyperplasia within the lamina propria, not too much in terms of inflammation, but you can also have a sort of superseded chronic inflammation within the lamina propria, and you can comment on that as well. And in terms of the acute gastritis patterns, I suppose the one that the moment we see activity, we always want to exclude Helicobacter pylori or HB gastritis. You may see them typically with other types of medications. I mean, there's really a spectrum of medications that can cause this, but the commonly seen ones are the iron-containing pills, NSAIDs, doxycycline, etc. Also, you may see a very focal evidence of acute gastritis, or focal sort of focally enhanced gastritis, as they would term it, where there's focal evidence of inflammation within scattered within the biopsy, and it's not diffuse, and that's sort of a harbinger of Crohn's disease. So Helicobacter pylori or HB gastritis. Helicobacter is a gram-negative helical or curve-shaped bacteria, and this is not the most dramatic example, and sorry, this is quite a superficial aspect because I was trying to sort of capture the organisms as well within. Sorry, someone say something? No. Right, and typically you will have a very dense lymphoplasmacytic inflammation filling and sort of expanding the lamina propria. And it's not so abundant here, but you may also see large lymphoid aggregates. And in terms of activity, you may see some of it in the superficial gastric glands over here. It's usually, there's a lot of active inflammation within the pits, but it's not, it is of course typical of an acute gastritis pattern, but it can be inactive as well. This is a higher power image to see where you may typically look for these organisms. They usually are sort of embedded within the sea of mucin and the surface epithelium. And when you see this, Bob's your uncle. You're delighted because you actually can find them. When they are within the pits, they are a bit more challenging to find, and certainly if they are not in abundance, it's always a struggle. And it's always described as a flight of seagulls. I have an image here. The only reason I included this the HB immunohistochemistry is to demonstrate that sort of seagull-like pattern that you see, if you at least indulge me. It does look like a bit of a bird, so perhaps we could go with that. So importantly, HB gastritis is very important to treat. Untreated or persistent H. pylori gastritis can of course lead to a maltoma or a malt lymphoma. And it's very important to treat aggressively with quadruple or triple therapy, whatever that's available or whatever that's recommended. So it's important to treat and recognize. So that's something that we look for immediately in every gastric biopsy. So this is just an example. The one sort of medication-related pattern that I have an example of here is the iron pill gastritis. Here you can see there's evidence of surface erosion, and you have these sort of dark, this coarse brown-black crystalline deposits on the surface, sort of stuck onto the surface, resulting in this kind of ulcerated pattern of inflammation. And the degree of acute inflammation can vary, and this is not a particularly inflamed or rather acutely inflamed biopsy. There's some neutrophils on the superficial aspect, but they can be very dramatic and with lots of inflammation depending on the degree of the insult. To further confirm the presence of iron, you could do a Pearl's iron stain, which will stain beautifully blue with Prussian blue staining, and this confirms, and this is an iron, and the bottom line would be an iron pill gastritis. Sorry. So in terms of chronic gastritis, now that's a heterogeneous group of disorders characterized by chronic inflammation within the gastric mucosa. The degree of inflammation can vary, of course, and I'd like to highlight the two most common causes of chronic gastritis, which includes autoimmune metaplastic atrophic gastritis, or AMAG. Commonly we refer to it as either autoimmune gastritis or just typically atrophic gastritis, and the other is the environmental metaplastic atrophic gastritis, or EMAG. And furthermore, you can have a chronic gastritis pattern with just the presence of replacement of the epithelium with intestinal metaplasia. And I'd like to briefly touch on lymphocytic gastritis as well. So autoimmune gastritis, or AMAG, is critical to recognize because there is an increased risk of carcinomas and more so neuroendocrine tumors. It's an immune-mediated destruction of the gastric parietal cells, resulting in vitamin B deficiency, which usually binds to intrinsic factor and it's absorbed within the ileum. So perhaps it's best to look at the normal physiology of the parietal cell to understand the sort of destruction and the effects of an autoimmune gastritis. This is your parietal cell, and this is effectively the proton pump. And the G cells within the gastric antrum secretes gastrin and stimulates the proton pump. It also stimulates the enterochromaffin-like cell to produce histamine, and collectively they secrete acid and intrinsic factor, which binds to B12 to be absorbed in the ileum. Now, this is when everything is hunky-dory and working fine. And if things are not working functionally, or you have this autoimmune destruction of your parietal cells and this atrophy, you no longer have, firstly, the loss of the feedback inhibition. G cells are overly stimulating gastrin. There's an elevated serum gastrin, of course. It overstimulates the ECL cells, and you get hyperplasia, which eventually, if left long enough untreated, will result in a neuroendocrine tumor. And B12 just goes unabsorbed within the ileum and results in pernicious anemia. That's effectively the cause and effect. And this is this may not be the highest power, but I just like this slide because it really shows the whole spectrum of morphological changes that you might see in the gastric body in the setting of atrophic gastritis. Now, you have sort of a gamut of features, including, the full gamut of features, including pancreatic heterotopia, perhaps not the first to mention, but you usually have within the lamina propria, I suppose, in terms of the inflammation, can be mild to moderate or, severe chronic inflammation. You rarely see any activity, but in terms of the metaplastic epithelium, you have intestinal metaplasia, you have some Paneth cell metaplasia here confirming that it's intestinal. You have little sort of bundles or bouquets of this pancreatic heterotopia, and you get pseudopyloric metaplasia. Now, when encountered, so how do you report these biopsies, or how do you actually formulate a report in general? Prior to this, a general rule of thumb, it might be good to throw a gastrin, because gastrin will obviously be negative in the body. And if this is antralization of the gastric body, it would be nice to do a gastrin stain to prove that this is in fact body that has been replaced or with metaplastic epithelium and is atrophic. But in some centers, and sometimes gastrin is not readily available to all of us, and a useful feature would be to look for the absence of those fried egg cells. So the absence of G cells within these pyloric glands will actually help and support your assertion that this is in fact antralization of the gastric epithelium. Also nice to do is neuroendocrine stains, because you'd like to comment on the presence of ECL cell or hyperplasia. It can be either linear, and it's usually a collection of more than 4 to 5 cells or greater than 4 to 5 cells, in a linear fashion, continuously staining for neuroendocrine markers. And over here, you have some early micronodular or nodular ECL cell hyperplasia, which effectively is the precursor to neuroendocrine tumors. And, it's important. I often like the neuroendocrine markers because, these little nubbins of nodular neuroendocrine cells may not be readily visible, and you might miss a very subtle neuroendocrine tumor. So the next is in the environmental causes of metaplastic atrophic gastritis, and it can be a spectrum of causes, and the morphological features are less sort of rigid and, with not the less pathognomonic. It can be a spectrum of features. So the causes are HP gastritis, as mentioned earlier. It doesn't necessarily have to have activity. Alcohol, bile reflux, NSAIDs, again, the usual insults and the common sort of characters that, result in these different gastritides. In terms of histological features, you may have a superficial plasmacytic infiltrate. The degree of inflammation can vary. And importantly, I should have said earlier, in terms of atrophic gastritis, it's sort of exclusively, it's usually confined to the gastric body itself. But in environmental, or rather the more typical environmental metaplastic atrophic gastritis, or the more typical chronic gastritis, they may affect the antrum more than the body first. There's a basal lymphoplasmacytic infiltration. There might be only patchy loss of parietal cells as a result of chronic injury, but you still see residual parietal cells. You may also see metaplastic changes. You might see, intestinal metaplasia as well, but you don't see the full sort of spectrum of features that you might see in an atrophic gastritis. And lymphoid aggregates, always do an HP stain if you can't see them readily. It's just worth doing, whether it's a GIMSA or immunohistochemistry. So this is just a quick sort of comparison of these two different common gastritis patterns. I think I covered most of this in terms of the distribution. AMAG or autoimmune gastritis is usually in the body, and it's antral sparing. The antrum can look, typically with just a mild chronic gastritis, or it might be effectively normal. And in the environmental causes, it tends to be multifocal. It usually involves the antrum first, and it might later extend to the body. And I mentioned the typical sort of metaplastic changes that you might see within the atrophic gastritis or autoimmune gastritis, including pseudopyloric metaplasia, intestinal metaplasia, pancreatic heterotopia, and it's effectively antralization. It's looking like antrum. And the more common, you don't typically see metaplasia, or you don't necessarily have to see it, but you usually see intestinal metaplasia in the environmental causes. And the key sort of histological clue is ECL cell hyperplasia, and also do not, always exclude Helicobacter pylori within the chronic active gastritis, or just even a chronic gastritis when you see there's too much inflammation to explain the morphology. So this is just an example of intestinal metaplasia, and in this case there's not too much inflammation within the lamina propria. The gastric epithelium is of course sort of replaced by intestinal metaplasia, and there are two forms of intestinal metaplasia, and I won't dwell on this, but it's either complete or incomplete, but this would look more like a complete replacement of the gastric epithelium with more intestinal type metaplasia. So I would say that would go with complete metaplasia, and it tends to be the more indolent. The incomplete one or type of intestinal metaplasia has a higher risk of cancer progression, or at least certain research has shown as such. Now, in terms of lymphocytic gastritis, usually it's the presence of lymphocytes of greater than 25 intraepithelial lymphocytes within the surface, and foveolar intraepithelial lymphocytosis, like within the surface of the epithelium or within the pits. It's usually CD3 positive, or could be CD8 positive as well. It's usually in the corpus, and however it may be diffuse. It has mild to moderate chronic inflammation, usually the absence of neutrophils, and it has a spectrum of causes. You need to exclude a Helicobacter pylori or HP gastritis. Often with celiac disease, you can see this, and certain medications, immune-mediated diseases such as Crohn's. Endoscopically, this may be normal in appearance, or you may have a varioleiform, sort of a nodular gastritis pattern. And this is an example of lymphocytic gastritis. And in fact, in this case, the patient also had celiac in the duodenal biopsy within the endoscopic sample. So it was very helpful to just sort of say, this is compatible with given the history of celiac disease. So you can see that the gastric epithelium and the pits are sort of studded with lymphocytes, and you will take my word for it that it's greater than 25 per 100 epithelial cells. Just as a higher power image, well, it immediately strikes you. This is not. You see this in your lymphocytic colitis as well, where you see typically there's an increased number of lymphocytes, and some a varying degree of inflammation within the lamina propria as well. The next pattern of injury I'd like to talk about is the vascular and hemorrhagic pattern. Typically we think about GAVE, or gastric antral vasculactasia, or the presence of portal hypertension. Now, they're very subtle. I mean, they can be very subtle on biopsies. I've often find I don't really see those very sort of dramatic GAVEs usually, but but that's what's usually represented in the textbooks. So in terms of GAVE, it's more commonly involves the antrum. In portal hypertension, it can involve all three sites, but apparently more typically in the body and fundus. In terms of the pathogenesis, I mean, obviously portal hypertension is due to portal hypertension. And in GAVE, it's not exclusively portal hypertension. It may be seen in cirrhosis or cirrhotic changes within the liver, which does result in portal hypertension, but it's not directly portal pressure driven. It could be mechanical, or there's maybe vascular injuries as well. Endoscopically, it's that classic appearance of a watermelon stomach with these longitudinal red strips. And in portal hypertension, it may be more of a mosaic with a snakeskin pattern with little red spots. In terms of GAVE, the key histological feature is the presence of these fibrin thrombi and fibromuscular proliferation. And in portal hypertension, you may just have dilated, congested vessels, and it's not typically, it doesn't typically contain thrombi. And epithelium is reactive. It may and may be present, and it's usually preserved in portal hypertension. It just looks quite clean. GAVE tends to be more dramatic. And I mentioned the presence of thrombi, and of course, the association with liver disease is actually both, and of course, portal hypertension within portal hypertensive gastropathy. Now, these are the endoscopic images. I purloined these images from a textbook. So this is your typical watermelon stomach. So it has this watermelon sort of linear strips. And this is, I suppose, snakeskin or more mosaic pattern, and they are somewhat distinct. And this looks more, and even just in terms of the endoscopic appearance, the GAVE tends to be more dramatic. You can obviously see more mucosal injury that may result in this sort of more dramatic histological appearance. And this is an example of GAVE where the surface epithelium is ulcerated and eroded with very large ectatic vessels filled with fibrin thrombi, and fibrinous exudate sort of strewing from the surface epithelium as well. And this highlights the smaller capillaries filled with these fibrin thrombi, and also smaller capillaries which are just dilated and congested as well. And in comparison, this is an example of portal hypertensive gastropathy, where it tends to be quite clean. And I often find it's of course an endoscopic correlation, and it's something that endoscopically, if they're querying it, it tends to be supportive. But if I had this in isolation, I wouldn't say absolutely this is pathognomonic for a portal hypertensive gastropathy. I do think that it's correlative, and correlation with the endoscopic findings and clinical presentation is important, but it typically does not have to be very dramatic. It has that sort of pseudo reactive gastropathy-like pattern. Here you see that corkscrewing of the gastric pits again, with the foveolar hyperplasia, but importantly, these multiple dilated vessels and the dilated congested vessels in the superficial lamina propria. Some are larger, some are smaller, but collectively the features would be supportive of a portal hypertensive gastropathy. Now into polyps and neoplasms. Now, I just cover the sort of quick sort of whistle-stop tour of what we may typically see on a biopsy. So the key approach to gastric polyps and biopsies is knowing, is it neoplastic, is it non-neoplastic, is there dysplasia or not? What does the background mucosa look like? Do you have HB gastritis? Do you have any trophic gastritis? Or are there any syndromic associations? And importantly, correlation with endoscopic findings. Absolutely, all the time, correlate with endoscopic findings. And even in terms of how many polyps are there, etc. And the first, and I suppose the commonest polyp that we see in our practice would be a fundic gland polyp. It's associated with PPI use. It's usually in the adult population because of this, because you don't want children to be taking PPIs, I suppose. And it's usually in the body and fundus of the stomach. It can vary in size. I mean, the vast majority are less than 5 millimeters, but they can be very dramatically large. And they can be multiple. It has a very smooth, sessile, glossy, translucent appearance, or little nubbins and nodules on the gastric surface. But importantly, it can be associated with FAP, or familial adenomatous polyposis, and then you get numerous funded gland polyps, and at a younger age, and dysplasia is more common. So it's important, again, to correlate with the history and look at the age of the patient, and assess the surface epithelium, particularly for dysplasia. This is just your, I would like, if I can use the term, common garden funded gland polyp, where you have this polypoid lesion, and this is probably less than 5 millimeters, of course. You have, it's lined by gastric foveolar epithelium, and it's sort of characterized by these dilated funded glands lined by a combination of chief cell, parietal cells, and mucus glands, and it looks very bland, very typical. And there's clearly PPIUs. It has this sort of like the parietal cells are very enlarged and sort of dilated and tumescent, having almost a sort of tombstoning effect in areas and resulting in this dilatation. And no dysplasia here, quite easy. So it's funded gland polyp, negative for dysplasia. The second commonest, or depending, would be the gastric hyperplastic polyp. It is predominantly in the middle-aged to elderly adults. It's most commonly in the antrum in comparison, but it may be seen throughout the stomach. They can be much larger in size, but usually less than between 1 centimeter and 2 centimeters, or it could be even smaller, depending. And when we get them in gastric, like when we get a gastric biopsy, and they don't do a polypectomy as such, they usually snippets the superficial aspects, and if they say polyp, you can say that the features are compatible with so. And they usually are solitary, but multiple lesions can occur. They tend to be sessile or pedunculated. Certainly the larger ones are pedunculated. And this is another sort of common garden, as it were, gastric hyperplastic polyp, where there's surface erosion. It's not that inflamed. I mean, despite its sort of very reactive appearance, it's akin to an inflammatory polyp in the colon, I suppose. And there's not too much inflammation within the lamina propria. When you see a lot of inflammation, you could look for H. pylori, and of course always look for H. pylori. But you could do a stain if you need. But in this case, it's very little inflammation. The surface is very eroded. There's a lot of foveolar hyperplastic changes, cystically dilated gastric pits at the bottom, and this is a bit of parietal, or rather gastric oxyntic mucosa. So this is probably in the body, and collectively the features would be compatible with a gastric hyperplastic polyp. And this is just a higher power image showing sort of the dilatation and the surface erosion. And the degree of inflammation and the degree of ulceration can vary depending on the type of polyp, or whichever polyp you receive. So in terms of adenomas, I'd like to just concentrate on the three most common, or the more frequently, pyloric gland adenomas are quite infrequent. However, the intestinal type adenoma and the foveolar type adenomas, now we are increasingly recognizing, are more typical in your everyday sort of gastric biopsy practice, or everyday practice. So this is just, it's quite a busy slide, but I just thought it was quite helpful in terms of, seeing the differences of the location and the background of the mucosa and architecture of these different polyps. A gastric adenoma is effectively akin to a tubular adenoma. It's, it arises in a background of intestinal metaplasia. So, and this is why there's always sort of a greater vigilance around intestinal metaplasia to exclude the presence of dysplasia, and patients are more frequently surveilled. Its architecture could be tubular villus or tubular villus, and it may look exactly like your colonic adenoma. And it's usually intestinal type epithelium, and of course it has goblet cells because of the intestinal metaplasia. And the dysplasia can vary, and all three polyps can show a spectrum of morphological, dysplasias, and ranging from low grade to high grade, of course. And foveolar, it's a type adenoma, is less common. And perhaps also less recognized, and I think we're seeing it more now, or rather recognizing it more now. It can be in the body or the fundus, but not exclusive. Like, none of these are exclusively located in either the antrum body or the fundus, but they're more typically found in the body of fundus. It's usually, the surrounding epithelium is usually normal. So in this case, normal oxyntic mucosa. You don't see any intestinal metaplasia. It can be tubular or villiform, and it has sort of gastric foveolar mucinous cells. It's usually lined by that. And you have the dysplasia is still associated with the apical mucinous caps. And that tells you that that's also another sort of pathognomonic feature, that this is foveolar in type. And pyloric gland adenomas are somewhat uncommon. We don't see them that frequently. I mean, of course, it depends on what sort of practice you have, but it's still relatively uncommon. But it's becoming increasingly recognized. It's more commonly seen in the body of the fundus. It may be associated with autoimmune gastritis or just atrophic mucosa, and it's characterized by closely packed pyloric glands, and it's usually pyloric type glands, and you don't have intestinal metaplasia again. And it's usually cuboidal or low columnar, pale sort of eosinophilic cytoplasm. This is your example of an adenoma. If I just took a smaller square of just the adenomatous component, you may think it's your colonic adenomas. So literally they are very morphologically identical. I took this image particularly to highlight that the background epithelium or mucosa shows the presence of intestinal metaplasia. And here you have your typical low-grade adenomatous dysplasia with this sort of picket fencing, this penicillate nuclei in this kind of a neat, tidy sort of basal row, with minimal stratification. So this is still very much low-grade, and it's quite organized. And of course, look for high-grade dysplasia would be akin to high-grade dysplasia that you see elsewhere, but this would be intestinal type adenoma with low-grade dysplasia, negative for high-grade dysplasia. The next two images are not fantastic, but do bear with me. And this is your foveolar type adenoma. The surface epithelium is lined by foveolar epithelium. And just looking in comparison, this is a lower power image that you can see that the surface is more higgledy-piggledy. It's a little bit busier compared to the gastric foveolar epithelium and the sides of the polyp. And it's within oxyntic mucosa. And on higher power, there is basal stratification. They still contain the apical mucin, but you can see that there's greater stratification, and they are sort of leading up to the surface, and they look somewhat distinct from your normal gastric foveolar epithelium or just reactive gastric foveolar epithelium. And in comparison to adenomatous dysplasia, the nuclei tend to be a bit rounder and, with sort of more coarser chromatin. Or the chromatin is more visible because they are rounder and more visible. And it's important not to overcall this as high-grade dysplasia, because it's just the type of epithelium that's giving you that sort of more rounded morphology. Apologies for this terrible image, but I just wanted to give you a sort of overview of what a pyloric gland adenoma looks on low power. It is it's quite exophytic and pedunculated, as you can see, and I'll give you a much better image here. It's just a higher power image of the same polyp, where you have these very tightly sort of packed pyloric glands, and the surface epithelium is also lined by foveolar type epithelium. And in this case, it's very bland. It's actually very bland. It's nice, round, basally located nuclei with abundant sort of eosinophilic cytoplasm, tightly packed glands with very minimal lamina propria between them, and that to me, this looks negative for dysplasia. And in pyloric gland adenomas, they don't necessarily have to have dysplasia. And of course, the grade of the nuclear cytology varies depending on once you get dysplasia. And given that these lesions can be quite large, it's important to assess the entire, go through it with a fine tooth comb to look for tiny foci of dysplasia. And a useful, I didn't usually do the immunohistochemistry, but I'm beginning to sort of lean towards them to help me. Well, when you have an intestinal type adenoma, it doesn't really matter. I mean, it is adenomatous dysplasia, so I wouldn't waste time doing any immunohistochemistry. You have the goblet cells, you have the intestinal differentiation. Important to recognize, because it does have the highest risk of progression to adenocarcinoma. And your foveolar type adenoma, and sometimes distinguishing the foveolar type and pyloric gland adenoma can be hard, because they both have that sort of rounded sort of nuclear morphology. So you may dabble in a bit of immunohistochemistry. So where available, I think foveolar type adenomas are usually MUC5AC positive, and it's variable in both other types of adenomas. And MUC6 is strongly positive in pyloric gland adenoma. In my center, we don't have MUC6, but what's useful is when you are trying to distinguish pyloric gland adenoma from any of the other two, or certainly from the foveolar type adenoma, I think it's usually a way to exclude the others would be to do MUC2 or CDX2 and MUC5AC. But if you have MUC6, of course, please by all means use that. And they are strongly positive for MUC6. So this is sort of a quick sort of overview of what might be useful ancillary tools to sort of distinguish between the three. But looking at the background epithelium is always helpful. And as you saw, the pyloric gland adenoma tends to be very dramatic and very pedunculated and large, and sort of has this kind of arborizing pattern. So just recognizing the morphology and low power is also useful. I'm not going too much into adenocarcinomas, but of course, mentioning the adenomas before, there is a high risk of progression, certainly with the adenomatous polyps into adenocarcinoma. And, generally gastric adenocarcinoma, akin to sort of gastroesophageal adenocarcinomas, they can be classified as mild, moderate, and severe. That's sort of, common, ubiquitous sort of histological grading system. But we more typically use the Lauren classification system, which was, established in 1965, dividing these tumors, or rather dichotomously dividing these two adenocarcinomas into the intestinal type, i.e. showing the glandular differentiation. This has a more tubular papillary architecture. This has a more tubular architecture. And so this would be called intestinal type. And the more diffuse type, which is very characteristic of these gastric tumors, is the presence of signet ring cells, like where these completely jam-packed with these signet ring cells that are tumescent with mucin displacing the nuclei, or just diffuse sheets of adhesive cells. And this would be called diffuse type. And of course, both can coexist within the same tumor, so both patterns can coexist. I typically would report these as, I would give a differentiation, and typically if you see these, the diffuse type pattern, you'd call it poorly differentiated, but you can say, mixed intestinal and diffuse types, and you can mention some of the types, and I often find that useful when we are reviewing frozen sections with gastric margins. It's nice to see a bit more of a descriptive report in the biopsies. It just helps you know what you're looking for in general, but won't go in too much into the adenocarcinomas, and just a very brief mention of them here. And the neuroendocrine tumors. So the neuroendocrine tumors in the stomach are all ECL cell derived, and they can be divided into types 1 to 3. Type 1, I briefly mentioned before, is one that's a result of autoimmune gastritis. So as I mentioned, there's ECL cell hyperplasia, which eventually leads into a neuroendocrine tumor. In type 2, it's usually seen in MEN1 or MEN1 syndrome, as everyone must know all the different types of tumors that arise from MEN1 syndrome, or Zollinger-Ellison syndrome. And typically both these syndromes result in the presence of gastrinomas elsewhere, usually in the pancreas, and there's a hypersecretion of gastrin, and it stimulates it's stimulating the ECL cells, which eventually will result in a neuroendocrine tumor. And of course, the sporadic form, which has no association with either, and it tends to be more aggressive. And I'm briefly going to show you a neuroendocrine tumor arising from in a background of atrophic gastritis. Here, I have a better image coming up, but you can vaguely see some intestinal metaplasia, and there's definite atrophy of the overlying surface epithelium in here, or rather within the superficial lamellopropia rather. And you can see that the biopsy is filled with this proliferation of nests and with this trabecular nests of small cells with, and you can imagine stipple chromatin in keeping with a neuroendocrine tumor, but I'd absolutely do the markers here. And a Chi67 or proliferation index of sorts. And here you have chromogranin highlighting this neuroendocrine tumor. This was a case that I literally signed out 2 days ago, and then I put it in the last minute in my presentation. I just liked it because it was a very, do you see that the neuroendocrine tumor, this is already a very superficial biopsy, but you can see that you may, everyone will pick this up obviously, but you just don't want to miss it because it can be quite subtle, where you have these little nests and trabecular, like cords and nests of neuroendocrine cells, which is part of a larger neuroendocrine tumor here, and showing a spectrum of changes associated with atrophic gastritis. You can see that you have pseudopyloric metaplasia and some glands peeking out of pancreatic heterotopia together with intestinal metaplasia. I thought it was just a nice image to illustrate the presence of neuroendocrine tumor with atrophic gastritis. And in terms of the terminology, so if it's less than 5 millimeters or 0.5 millimeters rather, half a millimeter, it should be termed hyperplasia. So, however, if it's greater than 0.5 millimeters, then it should be classified as a neuroendocrine tumor. Previously, the WHO used to classify it as a microcarcinoid, but that is a historical term that is somewhat redundant and antiquated at present. So please refrain from using that term. They're all sort of to be classified as neuroendocrine tumors. And of course, if it's greater than 0.5 centimeters, it's absolutely a neuroendocrine tumor. But there used to be this gray zone between greater than 0.5 millimeters to less than 0.5 centimeters, but now they're all sort of classified. So just it's the borderline sizes of less than 0.5 that you should be careful in terms of calling it. But as I sort of illustrated in the last slide, although subtle, and given that the biopsy was superficial, it's important to say that this is suspicious for a neuroendocrine tumor, and there might be an underlying larger neoplasm present. I'm not really going to talk about the mesenchymal lesions that we see, simply because in gastric biopsies we often get endoscopic reports saying, oh, we have a submucosal lesion, or we have a submucosal lesion or intramural lesion. That is not represented because often we only get the mucosal biopsies, and it's important, I think, to be cognizant of the location of mesenchymal tumors in general. For example, inflammatory fibroid polyps are usually in the submucosa. If you're lucky, they sort of sometimes leap into the lamina propria and you might see it, or the biopsy may include the superficial submucosa and you start seeing them. It might be helpful in an inflammatory fibroid polyp. You may do a CD34 to exclude it, but and a gastrointestinal stromal tumor, it's always in the muscularis propria unless it's very large. It might grow into the submucosa and very rarely into the mucosa. So it's often missed on mucosal biopsies or not sampled. Similarly, schwannoma, which is either submucosa or muscularis propria, and many sort of mesenchymal lesions have a similar sort of pattern of distribution. So whenever you get endoscopic queries or clinical queries of a submucosal, a deeper a lesion, certainly submucosal or muscularis propria, etc., suggest a repeat biopsy or different mode of biopsy to capture the lesion. So I've come to my conclusion slide. So just sort of like an overview take-home message at the end of everything. How we approach gastric biopsies in general. We look at the pattern of inflammation. Is it inflammatory? Is it reactive? Is it polypoid? And do you see in an infiltrative process or a neoplastic process? You want to localize these different the pathology rather. Is it in the antrum, body, fundus? And certainly it ties in very importantly with the physiology of the stomach and clinical context. So is something reactive or dysplastic? Look at the surface epithelium, look at the nuclei, look for the presence of dysplasia, atypia, architectural complexity, and have a very low threshold of showing these such biopsies, certainly with dysplasia in the sort of gastroesophageal region, is extremely contentious. Have a very low threshold of showing it to your colleagues, and certainly double reporting where it is mostly required. And also in terms of the gastritis, it's what is the etiology? H. pylori is the common sort of bad actor that's always present in these biopsies, or lurking and smirking in the corner, and it's important to exclude it. And as mentioned, the autoimmune gastritis, whether there's atrophy of the opsyntic mucosa, ECL cell hyperplasia, and whether there's a chemical insult, so is it a chemical gastropathy, and comment on the presence of atrophy and metaplasia. And lastly, you want to exclude a neoplasia, whether, and I mentioned this dysplasia, is this an early carcinoma, and to also consider neuroendocrine tumors. So thank you.
Sangeetha, thank you so much for this truly panoramic presentation of lesions one may encounter in gastric biopsies and the very logical approach. I think we've got time for a couple of questions, so if any of our colleagues joining the call today would like to type in any questions they have in the chat boxes, please, I'd be happy to share them with Sangeetha. And meanwhile, I think I will be opportunistic, and I would like to ask you, please, about the neuroendocrine hyperplasia and tumors, actually, with the cutoff of 0.5.
Yeah.
When you see something that's less than 0.5, do you confidently report it as hyperplasia, or you word the report?
Sure. Sorry, I was going to wait for you to finish your question. So effectively, it's what I said. So when we encounter an atrophic gastritis within a biopsy, you always do a neuroendocrine marker. You look for ECL cell hyperplasia, and that's when the neuroendocrine cells are not, obvious. But when you actually see a cluster of neuroendocrine cells, and as I mentioned earlier, they tend to be, these are superficial biopsies, and you have this tiny little nubbin of clusters, and it may be less than 0.5. It may be less than 0.5. When they start really just forming, it's more of an impression. When they start forming a mass forming lesion per se, I would have a lower threshold of saying, look, this may be. I would make a comment. I wouldn't just be confident and say it's hyperplasia. When you do see tiny scattered little nodules, now that collectively may be less than 0.5, but they have to be together to measure them anyway. So to answer your question, I'd have a very low threshold, of course, saying, or rather raising the suspicion of a neuroendocrine tumor, because you may be missing an underlying neuroendocrine tumor that might be extending into the submucosa or deeper. So when I do see a mass forming lesion, or when a collection of these nests of neuroendocrine cells, which are very borderline, I would absolutely raise the possibility of neuroendocrine tumor, and to exclude an underlying neuroendocrine tumor or a neuroendocrine tumor elsewhere in the stomach, really, especially with a background of atrophic gastritis.
Thank you. And do you in your practice, do you usually get endoscopic images with the request forms, or are there situations where you feel you need to go back to the clinical team and request endoscopic images or information?
We have an integrated pathology reporting system. It's EPIC, it's what it's called. So you have access to the patient records and endoscopic reports. The only challenge, to answer your question, for most parts, we do have the endoscopic images available to us at time of reporting, and it's on the electronic database that we use and reporting system that we do use. So you have access to everything for the patient as within the pathology reporting platform. The only challenge is if the endoscopic report hasn't been completed. That's when, or it's an incomplete report, I may not immediately have access to it, but effectively for all biopsies, the images are available to you.
And are there specific lesions or diagnoses that you would never authorize before having a look at the endoscopic images, or discussing that with the clinical team?
Yeah, I just, for example, I suppose that, you don't typically see them in the gastric biopsies, but I guess in an atrophic gastritis, I would be quite happy to go about it, and also correlate with the fact that, I think when you see a mass, it's important to correlate that, did they see a mass? And in terms of polyps, was there a polyp? When it's sort of incidental, you see some dysplasia, I'd like to know if they actually visualized a polyp. In those lesions, I will go back or may communicate with the clinicians, mostly in situations where the endoscopic findings are somewhat not in sync with your histological findings. But in terms of entities that I will report absolutely without, it's usually the mesenchymal lesions. I do look for adenocarcinomas that I see. I'd like to look at the endoscopic report to see the extent of the tumor, but that's more of a, you don't necessarily need it, but I would look at the endoscopic report to be sure. And certainly some biopsies are done elsewhere in our institution, certainly because it's a quaternary referral center. They may have had biopsies in the community. It'd be nice to compare the different types of histology because there might be a spectrum of morphological features, and you might be missing certain aspects with sampling. So in those scenarios, but I think with the mesenchymal lesions, if I do see them, and certainly when you get the transduodenal biopsies that you get, and they still are, whilst they're not endoscopic, I would absolutely look at it to see size, location, etc.
Great. Finally, I suppose with experience, you don't need to do immunostaining to identify a Helicobacter pylori in most of cases. But what do you see that would prompt you, or you would advise someone handling gastric biopsy? Once you see that, even if you don't see the HP, do immunohistochemistry.
Yeah, absolutely. So, like I said, when we see them, you're just delighted because they're usually in the pools of mucin, and you're very happy. And and sometimes when they're lurking in the pits, you can find them. But when I can't explain the degree of inflammation, so two scenarios that I might do it, and I used to have a sort of a higher threshold of ordering it, but now I have a lower threshold. Certainly when they query Helicobacter pylori, it is important that we certainly exclude it. Sometimes it's something that's ubiquitously written on forms, and you think, okay, this is just like exclude celiac, exclude HP gastritis. But when there is a degree of inflammation, usually moderate chronic inflammation within and it's looking a little busier and a little dirtier, and I can't find them, I would do it. But another scenario where I absolutely do H pylori, like HP markers or immunohistochemistry, usually would be in a post-treated gastritis, HP gastritis, because the inflammation may have sort of diminished, and the H pylori will sort of post-treatment will sort of change morphology. They have they develop a more cockeyed sort of morphology, and they're more rounded in appearance, and you won't visually sort of see them. And in that scenario, I almost always do an immunohistochemistry, even if I think, oh, this looks completely clean and there's only mild chronic inflammation, but I just want to be absolutely sure. But certainly when I have moderate chronic inflammation, no activity, but it falls into that sort of chronic gastritis pattern, that sort of EBAG category. I just want to be sure because they can be focal, and particularly if it's the distribution of the inflammation, or rather the organisms may vary within the stomach in the early stages. So you may be losing sort of the smaller clusters of organisms. So those are the few scenarios that I might do it in the absence, or when I don't obviously see them.
Got one question from the audience asking how long the chronic inflammation might stay after eradication, I suppose, of H. pylori.
I think that varies from patient to patient, to be honest. And as you know, some patients are more treatment resistant, so the inflammation may sort of persist, and that's when you have to be more aggressive, and you just want to make sure you want to exclude a maltoma or them developing a maltoma. But usually one hit of the triple therapy or quadruple therapy will effectively sort of resolve and settle the inflammation. I can't tell you exactly the length of time per se, but I find the repeat biopsies usually after 6 months, it's usually considered eradicated. And I still do, for due diligence, I would do a marker just to exclude it, but it varies from patient to patient and how they respond to treatment, I think. And also the volume of pre-treatment, the volume of the organisms and the insult.
Another question from the audience. Do you grade dysplasia in pyloric adenoma?
Yes, I do. Yeah. And in this case, this was negative for dysplasia, but if there's low-grade dysplasia, absolutely. And if there's high-grade dysplasia, absolutely. And you may even have invasive cancer, although I haven't seen it in practice, but you can have invasive cancer sort of arising from it. So yeah, absolutely, I do.
Right, I think our time is up, and while we did not have a lot of questions from the audience, we do indeed have a lot of thanks and comments on how great a presentation that was, which I definitely echo.
Oh, delighted. Thank you. I thought I was keeping it a bit too basic, but it's always nice to have a kind of a good review of what we do, even for me. Yeah.
No, absolutely. And I have to say, just a final word, when you said that your threshold is now lower for investigating H. pylori, I think that's actually making a lot of sense, because the more one is experienced, the more you see the subtle cues of a lesion. And that's absolutely a mark.
And there's also some argument that, recently, I believe it was Neil Shepherd who said in a presentation that, there are medical legal sort of, considerations later, if you didn't do your part of doing H. pylori. So it gets your sort of index of suspicion much higher and having a lower threshold. So it's funny, paradoxically, the more senior you get, I suppose, the more defensive you are in your reporting. But you're right, it's also picking up the subtleties and making sure you want to exclude, the rare, the subtle sort of, presence of organisms, etc.
Sangeetha, thank you very much for sharing your very precious time and expertise, and hopefully there will be future occasions of you joining us again and sharing with us your knowledge.
Delighted to be part of the webinar series. Thank you.
Pleasure to have you. Thank you all for being here, and wishing you all a fantastic rest of the day wherever you are in the world, and looking forward to seeing you.
That's right. It might be good evening for some. And in Canada, you are just in the middle of the day.
True. Right. We'll hopefully see you soon. Thank you very much.
Thank you so much. Bye.